When it comes to COVID-19, the science is changing rapidly. Every specialty is struggling to keep pace with the massive amounts of new information coming out virtually every day. And this is especially true when it comes to the heart. Today, I'm speaking with Dr. Yishai Szekely, a cardiologist from Tel Aviv University, about what his team in Israel has learned about how COVID 19 affects the heart by looking at echocardiographs of COVID 19 patients. Their paper was published last week in the American Heart Association journal Circulation. And what he says is that sometimes you have one idea about what's happening, but once you're able to visualize it, the results may surprise you. I think where I'd like to start is maybe you can just tell me a little bit about what prompted you to do this study. So, what was the impetus behind it?
Yeah, so this is actually, I can remember the exact time I thought about this, not as a study, but as a, I don't know, clinical decision. Um, since we started getting the information from China at, I would say, late February, early March, about the coronavirus and especially about cardiac involvement in coronavirus. We started getting all sorts of case reports about myocarditis, about stress cardiomyopathy, and about pulmonary embolism in patients with coronavirus. And then it was only the beginning, and most studies describing cardiac involvement were based on lab results, were based on troponin elevations, and none of them really had cardiac imaging described. So that's when I said, okay, we're starting admitting patients with coronavirus here in Tel Aviv Medical Center, and we might as well check each one of them when they are first admitted. We'll do an echocardiography with lung ultrasound to each one of them, even if they are only mildly ill, especially if they are critically ill. And let's see what we see. Let's see if the cardiac involvement is real. Is it true?
Yeah.
And that's how it started. We just started checking every patient that was admitted.
And what did you find? Like, can you summarize your findings for me in terms of what you were able to see?
Yeah, well, this is actually quite interesting because there's a lot of difference between what we expected to find and what we found.
Okay.
And I think that's the most interesting thing.
Well, tell me first maybe what you expected to find. I'm curious what you thought you would see.
Yeah, so as I said, the first information we've got from China and a little bit from Italy was mainly a dysfunction of the left ventricle. Obviously, if it's myocarditis, if it's stress cardiomyopathy, if it's acute coronary syndromes, secondary to the hypercoagulability. So we said we might find some interesting stuff in the left ventricle. But as we moved forward and another patient came, we saw that the real problem is not with the left heart. It's with the right-sided heart, with the right ventricle. And then it's like everything started to arrange because we heard about pulmonary embolism in the disease and thromboembolism in general. And we started connecting the dots. And actually what we found in the bottom line is that around a third of the patients who are hospitalized with COVID-19 have a normal heart. But around 40% of patients had some degree of RV, right ventricle dysfunction, to some extent. And moreover, if the disease was more serious when they were admitted, the RV involvement was larger, and there was more RV dysfunction in these patients. Moreover, when we looked at the patients with elevated troponin, where you would expect that the problem will be with the left heart, we found that in these patients also, the main problem is right ventricle dysfunction. And on top of that, we decided to do another examination to all patients who deteriorated during their hospitalization, whether it was respiratory or hemodynamically deterioration. And we found that in most of the deteriorating patients, the main deterioration was of the right heart. So you combine everything, and the bottom line for me, for sure, is that right ventricular dysfunction is the hallmark of cardiac involvement or manifestation in COVID-19. And that was the most important and I think the most interesting finding.
How do you explain that mismatch in terms of like what you said with troponin, where you would have expected to see the left heart involvement when you see this increase in troponin, but yet it's the right heart? Do you have like an explanation for that?
So I think the explanation explains mostly all our findings. And the explanation we thought about is that the problem is most probably not with the virus affecting directly the right ventricle, and not with the cytokine storm affecting directly the heart in general and the right ventricle in particular. But we believe that the right ventricular dysfunction is secondary to the pulmonary disease, both the pulmonary disease in the lung parenchyma and both in the lung vasculature due to the hypercoagulability and thromboembolic disease that we believe that has some part in COVID-19. So I think the troponin elevation is just a marker of right ventricle, which suffers due to the elevated pulmonary pressures, actually.
So is it, yeah, that the fact that the as the lungs become damaged, they're forcing the heart to work harder to do what it
Exactly.
normally wouldn't do?
We believe that the explanation is complex because the problem with the lungs is complex. You don't only find thromboembolic disease in the patient's lung. You, of course, find hypoxemia, which can cause vasoconstriction and elevate lung pressure. You find damage to lungs themselves, and it lowers the volume of normal lung tissue, which also can cause elevated pressures on the right side. And maybe we are to blame as doctors who treat COVID-19 patients and mechanically ventilate them with elevated PEEP, elevated pressures, which might also cause this kind of damage. So I guess it's quite a complex explanation, but it all leads to lung damage that leads to right ventricular damage.
I mean, and that sort of leads to my next question, though, which is like, how does this alter, your clinical treatment, right? So now that we have this information that we didn't have before, you were making a lot of different assumptions about what kind of heart damage there might be or where it was coming from. And now that we have a different picture, how does that impact things clinically in terms of moving forward?
Well, that's also very interesting because the first guidelines from all societies, from all cardiac imaging societies, said don't do routine echocardiography to every COVID-19 patient, which I agree with because, as we see, a third of them are perfectly fine. But if you look a little bit closer, you see that there is quite a large population of patients who could, I don't know, you can help them when you see their right ventricle, when you explore their left ventricle, because when you look at the patients we checked, some of the findings actually changed the way these patients were treated. For example, when we looked at around 20% of deteriorating patients during the hospitalization, more than half of them had a right ventricular dysfunction deterioration between the baseline echo and the second echo. Around half of these patients had a DVT, a deep vein thrombosis in their femoral veins. When we looked in the same examinations on their heart, we looked at their heart with ultrasound, we looked at their lungs with ultrasound, we also looked at their veins with ultrasound, we found a DVT. So this one thing led to another thing and led to a diagnosis which changed the way they were managed. And I believe we need to prove that, of course, statistically, but they became better after the right treatment. So this is just one example, but if you take, I believe, those patients who are more ill when they are admitted, they need oxygen supplement. Of course, if they are mechanically ventilated, those critically ill patients could really benefit from, I would say, a point of care echocardiography, lung ultrasound, and maybe even Dopplex of their femoral veins as well. This could change their management. Some of them had RV dysfunction, which was secondary to pulmonary embolism. Some of them, the minority, had LV dysfunction because of myocarditis, because of stress cardiomyopathy. And some of them were only septic and hypovolemic. And all they needed was a treatment for their sepsis or hypovolemia, and they got better. So I think, as in all critically ill patients, point of care ultrasound is a very good maneuver or examination to help you guide your management. And COVID-19 patients are not different in that manner. The only different thing is that you should look after yourself when you're performing these examinations, which was quite challenging.
Tell me a little bit about that. I mean, like, that must have been a difficult part of the study, right? I mean, the concern over you're getting infected as well, right?
Yeah. So the thing is, first of all, as I was involved in around 70 to 80% of the examinations performed in the study, I would say that the beginning was quite, how would I say, frightening, because it was unfamiliar, and you hear everything. You hear about the severe cases of young adults as well, and it's a bit shaky. But I would say that after a couple of examinations, after you prepare yourself with the right protection equipment, and you follow the guidelines, which I can elaborate.
Sure.
At the end of the study, I must say that I was feeling more secure inside the Corona ward or the Corona ICU, fully equipped and fully protected, than I was when I walked around the hospital with only a surgical mask, among the public.
Right.
I felt more secure when I was protected inside the Corona virus ward. So in terms
That's saying something, isn't it?
Yeah. That was, when I look back at the last 2 months, that's quite amusing, this point. So anyway, we did a couple of things in order to make sure that we're doing it right, and we're not exposing ourselves to dangerous, infection and the spread. So first of all, we used designated machines that were left inside the wards, inside the internal medicine ward that was designated for coronavirus, and inside the ICU that was designated for coronavirus patients. So we didn't have to transport machines. We didn't have to transport patients inside and outside the ward. Of course, we used a full PPE that included everything that is needed. We didn't miss anything. And we did not use any connections like ECG connections to the patients. So we try to minimize the contact between the performer of the examination and the patient himself, which is not perfect because you stand next to him for, let's say, 10 to 15 minutes each. But he's with a surgical mask when it's possible. You're with a full protection. You don't connect him to anything. And all measurements were done offline. So that really shortens the examination and causes the exposure to be, I don't know, less prolonged. Yeah.
Hmm. How did you manage, and then this is a little bit of a naive question, but how did you manage to do these recordings like without actually making contact with the patient?
Well, you do have to contact the patient. You're
Yeah,
in the same room,
yeah,
and you almost touch him. You touch him with the probe.
yeah,
Sometimes you have to move him a little bit in
yeah,
order to have better vision. So you have a contact with the patient, but you are
yeah,
protected.
yeah,
The patient sometimes can wear a mask himself when he's cooperative. So there is a contact that you can't eliminate that for sure. But after more than, I don't know, 150 examinations over the past 3 months, I would say that this is doable.
yeah.
This is doable, and I think we should not be intimidated by the possibility to help patient with point of care ultrasound, especially when it can be done by the treating physicians, which are exposed anyway to these patients. And this is a very important lesson I think we should learn from this era, that point of care ultrasound is something that clinicians should control, should have the ability to do, even in its basic form.
Hmm. I mean, that is probably a good lesson to take away from all of this, right? I mean, people may have been thinking that this was not something, like you said, that was necessary, that shouldn't be done, but you can see that like it actually does have some real clinical value in predicting how to treat these patients.
Yeah, well, first of all, we still have to prove it. Our study does not prove that patients' outcomes are better with point of care ultrasound. That's
Okay.
true. But if I have to say, my hunch is that it helped a lot of patients during these last few months. And I would definitely not exclude COVID-19 patients from the possibility to benefit from imaging, even if it's a basic kind of point of care ultrasound. By the way, not only echocardiography. Lung ultrasound, I believe, could be very important in these patients. We're just doing another analysis about that. I don't have the results yet, but we believe this is another thing you can do at bedside with these patients to help you risk stratify them and help you with resource allocation. Moreover, as I said, duplex ultrasound of the femoral veins helped us get a diagnosis of pulmonary embolism in some patients and treat them accordingly. So I believe it has a very important place in treating critically ill patients in general and COVID-19 patients in particular.
Would you say, just like based on what you were telling me before, that like as a general rule, are there a lot of cardiologists out there who are reluctant to do these kinds of echocardiography, that they feel that, like you said, it's either not necessary or that it does create too much exposure? They're wary of it, and that's why like this is important to sort of show that you can.
Maybe I didn't think about that way, but I have to say that in our department, after the first couple of examinations that were done, it wasn't a big deal anymore. Other physicians saw that this is possible, this is doable, the protection is complete, and when you do it right, you can do it. You don't have to do it to every patient. You need to be smart with patient selection, as always in every diagnostic examination, but it is doable. And as I said, not only by cardiologists. This should
Right.
be done by every clinician who takes care of patients or of critically ill patients and COVID-19 patients.
Okay. All right. Well, do you have any other like final thoughts of, summary take-home messages that you want to really like drive home from this study?
Yeah, I think that first of all, I think that one message is, as always in science and studies, is you think about one thing, you should be prepared to be surprised from another thing. And this is what happened to us. And I think it was quite a lesson for me and for all the crew. Um, and the second message, I believe, is that we should be we should use point of care ultrasound in critically ill patients, and um, we should teach clinicians to use this tool. I believe that listening to the patient is the most important thing, and looking at him or her is the next most important thing. But I believe that looking inside them with ultrasound might be the next most important thing and can help us a lot in understanding their disease and guide our treatment. So I would encourage every clinician, of course cardiologists, to learn how to use this tool, not only for the heart, but also for the lungs and for the veins and for all our examination of the patient, in critically ill patients in general and in COVID-19 patients. And you should not be intimidated by this disease. Just pick the right patients and try to help them. That's it.
All right. Well, thank you so much. I really appreciate the discussion. Very fascinating topic. And I think it's very illuminating to see how these things that surprise you, shake out.
Thank you very much. It was a
All right.
pleasure.